Hi, this is Dr. Kronowitz, and welcome to What's Hot in Plastic Surgery. I'd like to discuss with you today whole breast reconstruction. That means reconstruction after a mastectomy. There are several basic ways to think of it. Of course, the most basic is the use of implants or the use of your own tissue or flaps, as we refer to them. They can also be combined, where your own tissue can be combined with the use of an implant, but we're not going to touch upon that during this segment. So the use of implants have really increased over the subsequent years, and a lot of that is because the ability to perform better mastectomies by preserving the breast skin, and now even recently in more patients preserving the nipple and the areolar complex, has allowed us to get very good results using implant-based reconstruction, even when we're doing one of the breasts, not even doing both of the breasts. Another distinct advantage besides the ability to have a better envelope of skin and the nipple and the areolar complex is the use of fat grafting, or the injection of stem cells into the remaining breast skin to not only make for a thicker, more soft breast skin envelope, and often it can enhance the breast skin by healing it, getting rid of the scar tissue, and giving it a more rejuvenated appearance. It's especially helpful in patients who require radiation to the breast. In addition, we've been using a product that we refer to as acellular dermal matrix, which comes in many forms. There is a human form, which is actually skin from a cadaver that has had all the living cells removed, that allows for collagen to grow into it, and this provides many benefits for us and our patients, especially in regards to its ability to add a thicker layer of skin, like the fat we talked about, but also in a way to create a sling in order to coverage and to supply support to an implant or a tissue expander. Now, implant reconstructions can either go one of two ways. One we refer to as a one-stage or a direct-to-implant, and that means at the time of the mastectomy, we place the permanent implant into the breast skin envelope. This can be done by itself or combined with the acellular dermal matrix, or the ADM, which is becoming a more popular method of doing this. Fat grafting can then subsequently be combined at a later time in order to enhance the aesthetics of the breast. There's two-stage reconstruction, which is the more classic approach, which has its benefits and is still used very commonly today. And that involves the placement of a tissue expander or an adjustable saline implant, which allows us not necessarily to fill it up all the way at the time of the mastectomy. This can be very helpful in patients who do not have enough skin, in which the blood supply to the remaining mastectomy skin may be compromised, and we may not want to put all that pressure on the skin, which may lead for some of the skin not to survive. It also has other benefits in certain patients, and again, it's still commonly used. So that usually requires a second procedure, or the second stage, which is usually performed approximately 6 months later. At that time, the tissue expander is removed, the permanent implant is placed, often with the addition of some fat grafting at that time during the exchange. There are some other esoteric things that can be discussed with your physician, but in general, this is the most common way to go, and the way that I tend to utilize this process in my practice. The use of flaps are very common and have become more complex in time, especially with the use of microsurgery, and that means the ability to remove tissue from one area and to transfer it up to the chest wall, and using a surgical microscope to sew the blood vessels from that tissue, often from the lower abdomen, to the chest wall. And this can result in a transplant essentially on your own body, which is an excellent way to do reconstruction. It tends to improve the blood supply to the reconstructed breast, as opposed to what we refer to as a pedicle tram, where it remains attached to the muscle of the abdomen and then transferred to the chest. In addition, it tends to lead to less problems with the abdomen, although some patients can still get excellent results with a tram flap. The only difference is a deep flap tends to be with microsurgery, and it does not involve the use of any muscle in the transfer, which can lead to lesser morbidity or less complications in the abdomen for the patient. Now, the impact of radiation therapy has also really become much more popular lately, because it's been shown to offer a survival advantage to some patients. This can complicate breast reconstruction, and I personally have been involved in creating a lot of the methods that are used today, and that involves staging and saving the breast skin, not just getting rid of it or not saving it, which used to be done in patients, preserving the breast skin, lowering the tissue expander during the radiation so that we can have adequate radiation delivery, re-inflating after radiation, and then approximately 3 months after the completion of radiation, the expander is removed, and we either use implants with fat grafting, stem cells, in order to improve improve the outcome and to decrease the potential for complications, or we transfer the bone patient's tissues often from the abdomen or from the back area. And again, this has really revolutionized and become a very common and more popular area, and many surgeons can now much more reliably handle a patient who receives radiation therapy in association with breast reconstruction. I hope this was very informative for you, and thank you for tuning in to What's Hot in Plastic Surgery, and I hope to see you in my practice soon. Thank you.